I have to tell you, I've already made some really bad decisions today that I know I will be reaping the results of. So I decided that I could definitely come to Atlanta and give this talk, and I could make it a day trip from DC, which seemed like a great idea a few months ago because it would optimize my time and all that. And it was a great idea up until last night when I had to set the alarm for 3 a.m. to catch my flight. So I'm a little bit punchy. I've had a lot of coffee. And what that means is I'm going to try to cover my talk in about a half an hour, and I'd really invite as many questions as you have. And you'll get total transparency because my filter is turned off. So what I wanted to do a little bit is just tee up for you, just give you a little bit of information about the National Quality Forum, what we do, what our mission is, a little bit of the history behind it. But really I want to spend the most of this time talking about an effort that we engaged in for over a year now to really try to set a new course for the development of quality and value for the next decade. So we put together a task force at the beginning of 2019, and I want to tell you more about that task force and really spend the bulk of the time on that. But first, in order to do that, I think you have to know who we are, and this talk is going to start with a little bit of a risky exercise, but it's sort of risky for you and not so much for me. How many of you, with a show of hands, do not know what the NQF is? Maybe you've never heard of us, what we do. I've got to see hands, otherwise, there we go. Yes, that's how I know this audience is telling the truth. So the National Quality Forum is a nonprofit. We're based in Washington, D.C. We're about 20 years old, and our singular focus is on improving the quality and value of healthcare delivery in the United States. We really took a close look at our mission a couple of years ago and tried to make it much more expansive. So what you can see in our mission statement is that it is really important to us that we are a trusted voice for quality efforts nationally, and that we want to lead to measurable health improvements. So our focus is really helping to bring good measurement to the foreground, but measurement, as you all know, is not sufficient for actually driving improvement and change. And so we try to bring together various stakeholders and communities in healthcare to actually work collaboratively to drive that improvement. And our vision is really health focused. It is not just care delivery and healthcare focused. More and more our efforts have been working with community-based organizations in order to try to get the actual services that people need to them and not just necessarily the healthcare services. So I'll tell you a little bit more about all of those projects as we go along. Again, you all know the healthcare ecosystem, and it's complicated. This is roughly where we fit in the ecosystem. So what we are probably most known for in our 20-year history is creating standards for quality measurement. We actually review measures, we continue to do that, and we elect whether or not to endorse a measure. You can basically think of that as certification of quality measures based on scientific review and a lot of agreement that the measure is a good one. So we are not measure developers. There are a host of measure developers that include specialty societies, clinician groups. Obviously the federal government through CMS is a major measure developer, but so are other parts of HHS. The endorsement function is really meant to ensure that measures are checked, that they're validated, and that they're high quality. And we actually re-review measures on a regular basis to make sure that they still are the best measures that they can be. Then there's, of course, a number of organizations focused on implementation, delivery systems. There's accreditation bodies that get involved, like the Joint Commission and others. There's accountability organizations like the Leapfrog Group that really work to make this kind of measurement data transparent to the public. So we exist within a really broad ecosystem. We don't perform all of those functions, but what is important to us is that all of those functions be represented in our work. So let me tell you a little bit more about that. We have three main priorities at the NQF. First is supporting the transition to value. We've been intricately involved since the passage of the ACA in that transition to value, and actually our role was kind of increased with the passage of MACRA to facilitate the federal government and other players really adopting new value-based approaches. Our second priority is focusing on the big national issues. We have been a national player for our 20 years. I think we have a really important question in front of us about how much we can get involved on a more regional or statewide basis, but thus far a lot of our efforts have been focused nationally. And third is really focusing on population health. So let me give you a little bit more information about each of them. So in terms of supporting the transition to value, endorsement itself as a program has been really critical for us and I think for healthcare. We change our endorsement criteria routinely. They've been changed several times over the last 20 years. Our goal is to try to get measures into use that are rigorous, scientifically sound, and that emphasize certain principles like care coordination, care integration, patient-centeredness. So we assess measures for how well they encourage that kind of movement in healthcare, which I think of as fundamental underpinnings of the whole transition to value and why we are talking about value so much these days. In terms of national priorities, beyond measurement alone, we do try to focus on issues that are germane to today's system and where there's really demonstrated need today. We have a lot of work, for example, going on to address the opioid epidemic, both from a measurement and improvement standpoint. We have work going on to promote the implementation and adoption of telehealth, particularly around telebehavioral services. We have new work that's launching right now, probably an 18-month project that is focused on maternal health, maternal mortality. Again, we try to look at the environment and really respond to today's needs, both from a measurement and improvement standpoint, to make sure that we are addressing today's priorities, not just yesterday's priorities. And finally, we're really focused on improving population health. And I would argue this is probably our biggest area of growth in terms of new work. So we are trying to bring forward payment models that work to address population health needs. We're trying to better understand how measures can be used, not just at the individual level, but to assess the health and well-being of populations. So trying to focus, for example, on the development of measures around the social determinants of health. That's a really critical measurement gap today. There's very few vetted measures, rigorous measures that identify, for example, food insecurity in a population. We're working with some important stakeholders on developing just that kind of measure. So there's a host of work that we have going on along this strategic priority as well. So let's dive into the meat of this. So as I said, we're 20 years old, and I want to take us back a little bit to 20 years just to identify what it sort of taught us and then really talk about the task force looking forward. So 20 years ago, you might recall, there was a seminal report that came out in 1999 called To Err is Human. It was published by the then Institute of Medicine, which really identified safety and poor outcomes as major factors in the American healthcare system. So there was a figure that was published at the time of about 98,000 deaths, preventable deaths occurring as a result of American healthcare delivery. And this really focused a lot of attention. It was national news, and it focused the attention of a number of different stakeholders. And obviously the Institute of Medicine has continued to drive along that thread. These were the sort of shortcomings of the system that were talked about at the time. The medical error rate, obviously, the lack of transparency, rising healthcare costs, the lack of a broad, homogeneous culture of quality and safety. And so the Institute of Medicine at that time recommended 6 aims for quality improvement that are listed here. So they wanted care to be safe, effective, patient-centered, timely, efficient, and equitable, right? So that was essentially what came out in 2000 in their Crossing the Quality Chasm report. So we actually looked at that and asked the question historically, well, what has that accomplished and how should that inform the work then of our task force looking forward? So I talked a little bit about To Err is Human. I just want to read you this quote here. There was a President's Advisory Commission that was also executed around the same time as To Err is Human, which one thing that they noted is the American healthcare industry still does not have the ability to systematically measure and report on the quality of healthcare that is delivered to patients. In fact, if you try to put yourself back into the conversation that was being had in this period, there was a really fundamental question in front of us, which was, can healthcare really be measured? There were plenty of stakeholders arguing that it could not be measured, that it was too complicated, that their patient population was too complicated, that it just was not a task worth considering. So one of the things that this commission, this report, one of its recommendations was actually to create a private entity that would bring more rigor to healthcare quality measurement, and that private entity actually became NQF. So we're very much rooted in this history, tied together with IOM in many cases and with other organizations that really sprouted up around this time. So I would argue since then we've really executed 4 different phases of the quality measurement and improvement enterprise. So first is we define the problem. I think that's pretty clear. There are, again, a number of reports towards the turn of the century, which sounds odd to say now about our century, that defined the problem. We then actually demonstrated that quality could be measured. So there was a host of quality measure development enterprises that sprouted up. A number of those measures came to NQF as we first established and then enhanced our endorsement process. And now today we have about 500 measures that are currently endorsed by the organization. We again ask measure developers to come in for regular reviews of those measures to ensure that they should maintain endorsement. And one thing I'll point out is not all of those measures are in use across the system, and that's actually a challenge that we are looking at today to try to figure out how we as an organization should address it. I think the third phase that followed was public transparency around measures. So making the measures available on government websites, on private websites like Leapfrog, trying to put measures in the hands of patients and consumers who ostensibly should then use them to make their healthcare decisions. And I think the phase that we're currently in, at least for the last 10 years or so, has really been trying to tie measurement to value. So really paying for high value care, producing the right outcomes. And we will see, I think going forward, we will revisit many of these phases because the work in each of them feels pretty incomplete. I don't think we've done a great job, for example, on data transparency in quality measurement. We've had some really good results over the last 20 years. This is just a selection of some that was put together by AHRQ in HHS. So again, there are clearly some benefits to the work that has been done. This is obviously not NQF driven. We stand in the center, but this is really driven by the entire healthcare ecosystem. So clinicians performing their work more efficiently and better, patients being more aware and integrated with their care, insurance companies and payers driving improvement efforts as well. So I think the bottom line message for me is when we focus on a set of priorities and problems, we as a community can actually make improvement. But that is unfortunately not the whole story. So healthcare clearly has a long way to go. So this was a graphic on the left that shows causes of death that was assembled by who would it be? CDC, I think, in 2013. And again, medical error still ranks as the third highest cause of death in the United States. That was back in 2013. There was a paper then published in 2016 in BMJ that still estimated that it's still the third leading cause of death in the United States. And again, part of that is probably owing to better data. We just understand the data better than we did in 1999. And so that might account for why the numbers are actually higher than they were in 1999. But regardless of whether you believe that one number is better than the other, it's still really clear that preventable death is a major issue in American healthcare. So this, I think, is how we are now at the NQF envisioning the current quality landscape. So again, I think the number of issues has actually increased from 1999. And again, part of that is just we've built a certain enterprise. There are actually shortcomings of the enterprise that we have today. I think we've got to be upfront about that. So we have a lot of quality measures, but there's fragmentation in the measures. There's a large volume of measures. It's not clear that the whole improvement enterprise is driven strategically by a finite set of priorities. Rather, it feels like it's being driven in a very fragmented, siloed approach, driven by a number of different stakeholder types across the country. So I think it's, again, we've built to this point. There's clearly been progress made, but even what we have built up until now, I think has contributed to some issues and dilemmas that we now have to contend with. Data transparency is still a major issue. Healthcare disparities have fundamentally not been addressed. And so, again, I think the ecosystem is sort of begging for change and improvement looking forward. We decided, as we were putting together our task force, that the IOM 6 aims for care delivery were still appropriate, that they still had withstood the test of time, and we felt that we could build upon them. We actually just changed 2 of their aims. We turned effective care into appropriate care, because I think there's a growing recognition that we are not just focused on getting the care that has been demonstrated to be effective, but actually ensuring that care is appropriate in the first place, right? None of us wants to be the recipient or to suffer a medical error from a procedure that didn't need to be done in the first place. So we've got to move on from talking about effective care to appropriate care. The other change we made is we changed patient-centered to person-centered. And I think that really acknowledges all of the growing literature in the social determinants of health space, for example, that really acknowledges that, before we all become patients or even after we enter the care delivery system, there are unmet needs that we have that are really driven by our social context. And it's on all of us, I think, including the care delivery system, to help address those needs. So we launched this task force. The mission of the task force was really to be very actionable, to identify real opportunities for improvement. And as it says in the vision, we want every person in every community to be able to expect consistently and predictably high quality care by 2030. Now, think about that for a moment in your own lives and in the care of your own families. Can you walk into a delivery system and know that you will be consistently and predictably given high quality care? That there is no chance for error, that there is no chance for an adverse drug event? I don't think any of us, no matter what work we do in healthcare, can honestly answer yes to that question. Right? So I'm an emergency medicine physician, and I get concerned every time I or a family member walk into a delivery environment, because I'm fully aware of the errors that happen, the countless errors that happen that don't actually affect the health outcome of the patient, but the errors that do affect the health outcomes of the patient as well. We've got to get away from this system, right? It's got to be the case that no matter who you are, you can walk in and know that your care is going to be delivered effectively, it's going to be delivered optimally, and there will not be preventable adverse events that occur along the way. So that's the goal of the task force. Our task force was populated by a number of people. There's a lot of names on the slide. I want you to maybe get one message from this is we do all of our work at NQF in a diverse multi-stakeholder setting. So we are not aligned with any particular industry inside healthcare. All of our committees are populated by clinicians, payers, importantly patients, advocacy groups, technologists, experts, subject matter experts, et cetera. So the way we conducted the task force was very much the same. On this list, we have major delivery systems that are nationally known, regionally recognized. We have technology companies like Google and Microsoft. We had actually a representative from the automobile industry who works for an organization that works to establish quality standards in that industry. So it felt important to kind of bring that knowledge from another industry. And there's payers and patient representatives all represented here. We also made sure to create an infrastructure that allowed the public sector to participate because they have rules about how they can participate, and so we wanted to make sure that we were getting their expert input from various different parts of HHS, from the VA, et cetera. We set up 5 committees really focused on topical areas in quality and value. So first is clinical and quality alignment. So how well is the enterprise actually aligning with clinical workflows? We didn't want to ignore the topic of burden. We wanted to take it on directly, right? So we wanted to populate this committee with clinicians and others who would want to address the various shortcomings of the current enterprise because we felt we couldn't put forward recommendations if we weren't honest about where we were. Second, we had a committee on payment and policy. Again, now the intercalation of the quality enterprise with payment policy and payment levers is indisputable, and so we wanted to think about how to continue to push that forward. Third, a committee focused on consumer and community-driven care. So again, making sure that our recommendations and solutions would work for individual patients, individual people, but also the communities in which they live. And obviously we especially tasked this committee with taking on the issue of health disparities and the social determinants. Fourth was a committee focused on technology and transformation. How do we leverage new and emerging technology, the best technology, in order to push forward the quality and value agenda? And finally, promotion and system change. So we're acutely aware that lots of reports get published every year, including by us. How do we make this different? How do we actually get people involved? How do we get the American public involved to understand the shortcomings of the current approach and to become advocates for further improvement? And so this committee really has been thinking about how to get the word out about the results of the task force. Again, a lot of names. One thing I want to make sure that you know is that every single one of these committees, including the central committee in between, was populated with patients. So we made sure that there was at least one and more than one if we could on each one of these committees so that the patient voice was being represented. And that's, again, a central hallmark to NQF work. We don't launch a committee without a patient on it. So this is actually one of the patients that served on the committees, and I think her comment, I put it in this because I think it really just captures the hallmark of the issue, right? So she said, Joan Maxwell, who's this incredible speaker, and she was actually at our annual conference a couple of years ago. She's participated in a number of different projects that we've executed. She said, unfortunately, care is still very siloed, but patients don't heal in silos. I could basically stop talking, and that would be the essence of the report. And who better to capture it than a patient who's been through the system and been through it extensively. So a lot of our work really focused on trying to break down these silos and respond to this, I think, central challenge. So I'm going to talk about, I think, 6 themes that emerged from the task force. I'm walking a bit of a tightrope here. We're done with the task force. We're writing up the final report. We're going to release it in March. We have 10 very specific recommendations that cross all of these themes and that we hope will guide the next 10 years. But I can't scoop myself. We're releasing the task force in our annual conference in March, so I'm going to give you the themes that really came out of it, and they will point to the recommendations, but they won't be the recommendations. And in some cases, I'll just tell you the recommendations. All right, so here we go. So a first major theme was emphasizing appropriate care. I talked a bit about that already. 10 minutes already. All right. And population health-based payment. So it was the Payment and Policy Committee certainly focused a lot on how we should be paying for care delivery in order to ensure quality and value. But this was, as you can imagine, a foundational theme that ran across all of the committees. And what we will be doing in the context of the report is supporting various specific goals for how much of our payment should be moved towards population-based models and by when. So it is clearly thematic, and I hope you would all share this in the room. The fee-for-service model does not focus on the right aspects of care delivery for patients. We have to continue to move away from it. I think certain progress has been made, not frankly as much as I had probably hoped 10 or so years ago, but progress has been made, and I think the big push here is that we continue to focus on population-based payments so that healthcare, health delivery can really focus on the kind of care that patients need wherever they need it, whether that's in a traditional delivery setting or in the community setting to address, the social context in which they live. So I think hopefully a lot of this will resonate with you. And again, I think there is this focus on appropriate care, not just effective care. That was a point that I made earlier. A second theme was activating consumers. So it's been demonstrated in the literature that if you are a consumer that's activated, you're 4 times more likely to engage with the delivery system to actually get the care that you need and not have as much unmet medical need as a consumer who's not activated. So the question is, how do you really get activated consumers? Is it just about giving them data on the back end of measurement? You know, we go through all these activities to define measures, we get delivery systems to collect data along those measures, and then we put them on a website. That's sort of been our approach nationally to date. And the fact is, that's not activating consumers. Very few consumers actually use the data that's put online. Very few consumers make decisions according to that data. And let's just be honest, very few consumers have the ability to make decisions, the leverage to make decisions using that data. So truly activating consumers, we feel, means putting patients up front in the process. They need to, if not actually define the priorities, at least strongly contribute to the priorities. They need to help us conceptualize what good measurement looks like. They need to be involved in measure development and in data collection. Consumers, patients need to be involved in every step of the process. So I'm going to give you one example from another project that we executed a couple of years ago. A measure developer approached us wanting our assistance in developing patient-reported outcome measures for rheumatoid arthritis. Their focus was rheumatoid arthritis. Obviously, the quality community has been talking for a while about having more patient-reported outcome measures, and still to this date, very few are in development. So this was an exciting project for us to engage in. Importantly, the developer said they wanted patient input on what those measures would look like on the front end. So they had conceptualized certain measures that they hadn't been developed yet. They wanted patients to feedback on those measure concepts. And so we engaged a social network platform, and we got tens of thousands of patients with rheumatoid arthritis to give them feedback on their measure concepts. And what they learned, maybe not unexpectedly, is that their concepts had nothing to do with patient need, like literally nothing to do. Patients were focused on a different set of issues than the measure developers were. They were focused on a different set of symptoms, and one really big change or difference is that they were focused on the consequences of their treatment regimen, sometimes more so than their disease symptoms. That was a fascinating lesson learned. But it shows you that if you involve patients, the answers will be more germane to them, and frankly, they'll be very surprising to the rest of us who are trying to help them, but from an outsider's perspective. So that was a really big lesson for me, for us at NQF, about what activating consumers really meant, and we tried to imbue that kind of thinking in the work. A third theme, I think hopefully this will resonate immediately with you, is the need to standardize quality data to make it seamless and to make it actionable. So right now, quality data exists in a lot of different silos. If you are not 65 and over, you don't have even the benefit of Medicare data to rely on to tell you anything about quality. If you are 65 and over, the Medicare data may or may not actually address your needs. So data is extremely fragmented. It's widely not available. There's actually very little of healthcare data that's available to the rest of us. And Deputy Secretary Hargan talked about all the things that they're doing at HHS to emphasize and promote care coordination. And those things are exactly right. But if you think about what we have today, we do have a system where you can get telehealth over here and you can go to the right pharmacy over there, but none of your data follows you. We need to solve that, right? Data must follow the patient to promote care coordination so that, again, clinicians and others who are interacting with the patient are completely aware of what has been going on with them and around them. So we will be putting forward themes and recommendations around creating standardized quality data sets, standardized measure sets. We too at NQF want to get away from the sort of overburdened, fragmented quality measurement enterprise. We can do that through standardization. So one of the things that we're actively working on now is we help to launch this thing called the Core Quality Measures Collaborative, which seeks to create measure sets that can be adopted by both the public and private sector. And again, this is a multi-stakeholder exercise. We get everybody in the room. We have, I think, about 10 measure sets today along a host of different clinical topics. And are looking, of course, to develop more. But the whole goal of that is to move away from different payers and different delivery systems using different measures and to try to get them to adopt and adapt certain standards. So I think that can be jump-started further, but those are the steps that we've been able to take thus far. Another theme, again, should totally be expected, I think, to you, is addressing social determinants of health. I won't belabor this too much. I think there's been a lot of really good dialogue and discourse recently on the impact of social determinants and how they actually change both medical outcomes and health outcomes for individuals. But this has been a central theme in the work and really thinking about how we leverage all of the different, whether it's payment models or clinical approaches or community-based approaches to address social determinants. Maybe the one project I'll mention for you is we convened in last year a payment summit around social determinants. So a summit really focused on what have we learned in addressing social determinants, what payment models work in order to be able to put forward recommendations that can be adopted more widely. So again, this has been a theme that we've been focused on for a while, and we wanted to make sure really resonated in the task force. Next is integrating innovative modes of care. So this, as I mentioned to you, we had a technology committee for the task force. They're really focused on how to leverage new and emerging technologies to actually improve care delivery. And so what we will be putting forward are principles around when technology should be adapted by the healthcare environment, right? And we really focused on three main principles. First is that technology has to improve efficiency of the system. If there's technology that is not improving efficiency or actually hurting efficiency, then that's a challenge, that's a problem. Second, the technology must really improve outcomes and safety. Again, it's got to demonstrate with real data that adopting that technology, introducing it, integrating it, whether it's in the community or the healthcare system, actually results in improved outcomes. And third, it has to improve accessibility. We really feel like if you're not meeting at least one of those goals, then the technology may not have the right return on investment for healthcare. And so what we'll be putting forward is the whole idea of a technology evaluation framework so that new technologies can be assessed rather than healthcare kind of jumping from one shiny object to the next. So this became a really important piece of work for us will be, I think, an important recommendation. And finally, and certainly not least, is cultivating the right workforce. So this has been talked about a lot by numerous organizations. I think we've got to do more and better to really identify outstanding examples of where care delivery has been improved or where outcomes have been improved, and to get that kind of thinking imbued in our workforce. So I've certainly experienced this throughout my training and practice as an ER doc. I've worked in environments that are really good. They have a culture of safety and quality. They teach you how to do better. There's a systems approach to doing better. And unfortunately, I've worked in places that are not like that at all. I think we've got to really standardize our thinking about what excellence looks like. We've got to make sure that we highlight exemplar performers, but really then normalize that kind of care. That's the step that we haven't taken thus far. There are systems out there that are doing great work, absolutely. But we have not normalized that kind of high-value, high-quality care delivery. And so we'll be putting forward ideas about how to actually normalize it so that it becomes the usual care instead of the exemplary care. So those are the main themes that I wanted to discuss. Hopefully you have lots of time for questions. Again, we'll be releasing this report in March at our conference, and I invite you to attend.
Thank you, Shantanu. First question.
Thank you, Dr. Agarwal, for your great presentation. Let's see how many questions we got. Right there. Let's get started.
Thank you, Doctor, for your talk, your topic. It was very interesting. I actually work for a small company that has 2 NQF endorsed measures on rehospitalization for short-term and for long-term patients. And I was wondering if you could talk about, we see a lot of people measuring rehospitalization all sorts of different ways. So I was wondering if you could talk about sort of the reason why they should care if something was NQF endorsed or not, and perhaps some of the pitfalls of using measures that aren't.
Thank you. I'd love to talk about that. Look, we do 2 things fundamentally in the endorsement process. We've created scientific criteria for what a good measure looks like. We assess the statistical model behind it. We assess things like the validity of the measure, the reliability of the measure. Importantly, we also ask measure developers to do some testing on their measure and ensure that there's an actual improvement gap that they are looking to remedy, right? So you might have the greatest measure in the world, but if there's no fundamental improvement gap, if people are doing relatively well on that measure, we're not going to endorse the measure. There has to be a reason to go through the process of putting that measure into use, of sort of creating the administrative work around that measure to necessitate its use. So again, we check the scientific validity of it, and then the other aspect of endorsement is we get broad consensus that the measure should be endorsed and that it should be used. So we do that by actually leveraging 14 different committees. These committees are organized by various topical areas. And each committee, just like, as I mentioned for the task force, is diverse in its makeup. So there's patients and payers and clinicians and subject matter experts on those committees. They have to agree in a consensus model that the measure meets the criteria and that it's a good measure. So just meeting the criteria is actually not good enough. They have to view it as a measure that's important to further healthcare. And so that's the process that we undertake. We actually make sure that the process is sound, that it's executed the right way, but it's the committees and the set of stakeholders that recommend to us whether or not the measure should be endorsed, and then we basically follow their recommendation. So that's really what you get. When you get an NQF endorsed measure, it's scientifically sound and it's been reviewed, which for many systems, if you think about driving change in a large delivery system or in a state or whatever setting, those 2 factors become really important, and it differentiates an NQF endorsed measure from one that's not.
So, see one more question. Okay, go ahead.
Hi, Fahad Rahman with Lumi. I think the last time you and I chatted, this was some years ago, we were both in payment and program integrity, so it's been a few years. So, this is great. I've worked with hundreds of physicians, and at the point of care, if I could channel their thinking, there's a tyranny of quality measures, which is that it's an ever-expanding set of process excellence things that often translate into increased documentation and not as much time focused on actually clinical outcomes and so on and so forth. So, effectively, a lot of the measures, and not you guys specifically, but the world of the quality measures entities, you have a lot of process excellence, but how do you guys think of systems of care? Because actually, all the clinicians we've ever worked with, they don't think of a measure, they think of a patient, a condition, a category of care. So how are you thinking about systemness as opposed to process excellence? Because without that systemness, you actually can do hundreds of things right, but then not see meta outcomes improve in terms of utilization or clinical improvement.
Yeah, it's a great question. First, I want to start by addressing, I've never heard the phrase tyranny of measures, but it's a pretty good phrase. Look, I first want to validate that viewpoint, right? There are a host of originators of measures and a host of reasons why various measures are put into use. And there are bad measures and good measures, and there are process measures that are very microscopic and atomistic, and other measures that are far better than that. I once met a company, it was a for-profit company, they sold measures to delivery systems, and they looked at me with pride and they said they had 2,000 measures. And I asked them to stop selling them. 2,000 is way too many for one delivery system, and yet they're not the only originator of measures. So I do think it's important that NQF play a role in trying to winnow down just the sort of the overall measures that are in use. We utilize endorsement to do that, and there are other programs that we try to do that through as well. Your question about systemness is, I think, exactly right, and it reflects our own sort of thinking. We've evolved in our view on measurement. We actually do view measures working together in systems, both measurement sets, but also now, perhaps just as germane as the payment system in which those measures work. So we have started putting more of our work into what we call the measurement system domain. We're actually trying to create, again, we're a very scientifically driven organization, so we're trying to create the science behind systems, trying to understand how systems of measures work together, how they should interact with the payment system. There's important measurement issues like attribution that get involved when you look beyond the individual measure, even how measures will form a composite. There's people far smarter than me in NQF working on these topics. One thing that we did as just almost a validation exercise is we took a deep look last year at CMS's Hospital Compare program, which is a system of measurement. It takes a bunch of measures, it aggregates them with a very specific methodology, and then it assigns a payment method behind that aggregation. And so we really asked, how does that reflect the science that we're uncovering in measurement systems? And we put out a report on that with several recommendations, but that was a sort of a milestone in continuing the work, and we'll actually be releasing in March, if you're interested, if you're a measure developer or you're interested in measurement, we're going to be releasing a technical report in March really focused on this question of assessing measurement systems and how good systems of measurement are, precisely so we can move away from what you're describing, which is these really atomistic, did you execute this process, did you achieve this specific outcome, but really looking at patients as a whole.
Further questions?
There's a question over here.
Hold on just a second. Why don't you get the microphone, please?
There is something called quality metrics, which is clinical classical. Means in the clinical practice of medicine, it has been stated that a patient who has been seen by a doctor or healthcare entity and then sent home, discharged, should live at least for 24 hours. I see every single day violation of these quality metrics. The people get discharged, and then they're baked in the emergency room and intubated, and many of them, they die. And nobody pays attention to this. That's the problem we have.
I think that's really interesting. So we are trying to pay attention to that. A lot of, the readmission measurement work that was mentioned earlier, that is really focused on what are the consequences of that initial hospitalization. Does the patient end up coming back to the ER? Do they end up getting readmitted to the hospital? There are measures that look at continuity of care around sort of an initial event or an episode. We're starting to approach that work. I think your central point is still right, that it's not sufficient, it's not as evolved as it should be or that we need.
You should have a hotline.
A hotline?
You should have a hotline, a nice toll-free numbers, so that people can report these violations, quality violations to you.
Actually, we do, I think.
So
New York State
HHS
Department of Health actually requires us to
Yeah,
report
so
that.
HHS does have a hotline. I want to be clear, we're not a regulatory body. We try to facilitate a bunch of different organizations. Again, I think the central point around looking at the consequences of care is absolutely right, and I do think there's some really good work happening there.
Right. Department of Health actually has a glossary that meets that requirement. So if there is an event that happens within 24 hours of discharge, we have to report it. For New York State, at least, there is one.
Now, who reports that?
The hospital reports it. Yeah.
And they just don't.
I think that's the part that it's a culture change, right?
That should be given,
Yeah, I agree.
and that's why there is no teeth.
Right.
You know, we can talk all the great things, but if we, it's like we eat food but no teeth in the mouth, you know?
Thank you very much. Anybody else has any questions? I just want to make sure that we give Dr. Agarwal some time before we start the next session, and I know his 3 a.m. journey.
I'm going to take a nap right after this.
Again, I think we have a couple of more minutes. He can take questions afterwards as well. Thank you very much,
Thanks
Dr.
very much.
Agarwal, again. I appreciate your help. Thank you so much. Again. Appreciate it.